Hello, everybody. Today I'm going to present a brief talk on marine emergencies. I'm going to keep it very simple. I'll divide it into two parts. The first part is going to be on barotrauma or dysbarism, as well as decompression sickness, which is all ill effects of pressure during diving or marine activities. And the second part is going to be a discussion very briefly on marine envenomations. So let's get over with the very important but not so boring gas laws which are related to this. We need to understand that the pressure effect comes from two sources. One is the ambient gas pressure, and the second one is the breathed compressed gases which are breathed by the diver. So, what are these three laws? Basically, the Boyle's law, in simple terms, says that pressure and volume are inversely related. So, if one increases, the other is going to decrease, and the other way around. And the Henry's law states that the quantity of gas within a solution is proportional to its own partial pressure. And the third, very simple mention of Dalton's law is that total pressure exerted by a mixture of gases are equal to their own individual pressures summed up together. So now we are ready to understand what is barotrauma. Basically, any gas containing cavity, uh, if there is an ill effect due to the gas compression, then it can happen while the diver is descending or while they are coming up to the surface. And this is termed as barotrauma. And when it happens during descending down, it is usually called squeeze. And squeeze can happen in any enclosed space, which may be the skin, ear, sinuses. We can see here, this is called as the face mask squeeze. And it usually happens due to the failure to exhale via nose whilst wearing the face mask. And it causes erythema, bruising, petechiae, and subconjunctival hemorrhage. It can even happen within parts of the diving suit. So the skin has the similar kind of appearance here. Usually, no treatment is necessary and they get better on their own. What is most common is barotitis media, which is basically the middle ear squeeze. This is precipitated due to eustachian tube congestion, and it presents as erythema, hemorrhage, and even tympanic membrane perforation, leading to conductive deafness. Uh, More rarely, it could have an effect on ear, and the round and oval window might rupture due to sudden pressure changes between the middle ear and the inner ear. That presents with acute tinnitus, vertigo, and deafness. And sometimes it can happen that there is a perilymphatic fistula that develops, which is an indication for ENT referral. As well as if all these signs and symptoms they are persistent, then we need to make a ENT referral. Treatment depends on whether or not the tympanic membrane is ruptured. If it is not ruptured, then usual analgesics and decongestants are fine. But if it is ruptured, then antibiotic, and to advise that diving should not be undertaken till all symptoms have resolved and the tympanic membrane has healed well. So the opposite of this is otherwise called as reverse squeeze or ascent barotrauma, and that happens because of uncontrolled rapid ascent as accompanied with breath holding. So uh, this usually affects the lungs, and this is more so seen in asthmatics and people who didn't know that they had congenital lung bullae. And what it can cause is basically mediastinal emphysema, which usually presents with hoarseness, neck swelling, and retrosternal chest discomfort. It can even cause pneumothorax, and as we can imagine, if the pneumothorax develops while ascending, then that can be life-threatening because the intrapleural gases cannot be vented, and as the diver is ascending, the pressure will increase, precipitating tension pneumothorax. And if they have reached the surface, obviously clinically diagnosed, and the usual decompression methods as well as chest drain is the treatment. For any kind of effect due to barotrauma, the initial treatment while stabilizing the patient should be oxygen as high as a concentration that is possible. One of the milder effects that can happen whilst descending or ascending is pain in the tooth, usually those which have caries as well as those which have been recently filled because of the airspace that causes increased pressure. And as I was mentioning about ear injury due to barotrauma, the similar kind of sign symptoms can develop due to sinuses causing barotrauma as well. Now we move on to the more important aspect of this, which is decompression illness. To understand decompression illness, I would like to focus on this image. So there is pneumothorax and mediastinal emphysema and subcutaneous emphysema, but alveoli can rupture, causing air to leak into the capillaries. That in turn can go into the left side of the heart, um, and then into the systemic circulation, and can even progress to reach as a cerebral embolism, which is otherwise called as CAGE, cerebral arterial gas embolism. It is difficult to differentiate whether it is just an ascending barotrauma or it is a proper decompression illness. So usually this CAGE is also referred as a part of DCS, but a more severe form. So what is the pathophysiology of decompression illness? There can be two issues. One, dissolved nitrogen in blood and tissues are not released at sufficient rates. So bubbles get formed and they get deposited in various spaces like joints and skin, etc. Um, and the second issue could be air bubbles, as we discussed in earlier, that air embolism can cause the bubbles to come into circulation, which can in turn uh, cause effects due to deposit in vital organs. So few people have risk factors, which are like, especially if they are not following the safe ascent recommendation or they are indulging in excessive exercise whilst diving. Obesity and very cold water is also a risk factor. And after the diving, if there is insufficient time given between diving and air travel, so then residual nitrogen can't leave the body in a controlled fashion, causing bubbles, and then mechanical and inflammatory effects develop in whichever tissue they go and get deposited. Uh, so based on the tissues that they get deposited, DCS is divided into two types. Type 1 DCS is basically pain in joints. The most common are shoulder and elbow. um, Usually these joints are not tender, but on moving them they are painful, and the achiness without moving is described as quite dull. It can be associated with pruritic rashes, local swelling, and pudgy orange like bumpy skin. Type 2 DCS is when the spinal cord gets involved. They usually present with back pain, limb weakness, sensory abnormalities, and retention of urine. It can even happen with cerebral DCS, like effects with focal deficits, cerebellar disturbances, and mood changes, which is more severe. As we can see that pain is the most important presentation, but we should not attribute them to musculoskeletal sprain, strain, or minor injury, especially when it is after a diving episode. And we need to realize that quicker the onset of symptoms, the progression might be more severe. And as we can imagine that recompression would be the treatment for decompression illness, but interim, by the time we are, because all areas would not have a hyperbaric chamber or facilities for recompression, in the interim the highest possible oxygen concentration should be delivered to the patient. Any delay in recognizing or specific treatment can actually lead to permanent brain or spinal cord damage in type 2 DCS. And sometimes it is so difficult to diagnose them that recompression response might be the only method to diagnose that this was a decompression illness. It is of note to understand that analgesics and sedatives, which are commonly given, may mask this kind of recompression response. And I'm just going to tell a few more tips about the treatment, because the specific treatment is very specialized. Uh, in the initial stages of treatment or stabilization, because pain is the most important or commonest manifestation. We need to understand that Entonox is absolutely contraindicated because it is just going to worsen bubble formation and other aspects, as we understand. uh, if intubation is necessary prior to transferring or for stabilization, then sterile water should be used, because the balloon might deflate whilst recompression happens. And other supportive measures which are advocated by many centers are IV fluids or plasma expanders, because they will improve oxygenation in these ischemic tissues due to the embolism itself, as well as they will facilitate tissue nitrogen load into the venous system to get rid of them. Aspirin and dextran solutions might be advocated in those specialized centers or even prior to be transferred, because they help with the capillary sludging that happens with decompression sickness. And also temperature, the patient's temperature, although the diving suit is considered to be dry, whether or not they are wet, hypothermia is very commonly associated with diving emergencies. Air evacuation needs to happen in most of the cases to the specialized centers. We need to remember that if they are unpressurized aircraft, they should not fly more than 300 meters to avoid further complications. And during transfer, 100% oxygen, in most of the cases, the patient will need to be intubated. On reaching the diving center, what exactly happens? So on the right lower, we can see the James Paget's hyperbaric unit. Basically, on reaching there, they simulate a depth of 18 meters with 100% oxygen and interspersed with air breathing to avoid oxygen toxicity. Then a slow decompression protocol is followed. Prior to transferring, it might be useful to send the patient along with their diving equipment, because that may give more idea as to what exactly happened. And also, divers usually have buddies, and these buddies may be at risk of the same problem, although they may not need recompression. So it's useful to send the buddies along with the patient. What kind of information is required to make these kind of referrals? Obviously, the patient's current condition, the progression since onset, what treatment was given and what was the response, what was the time of onset of the symptoms with respect to the diving episode, what was the dive profile and the history of the incident, because this is usually the professionals record it. So depth, duration, activity which was involved in, speed of ascent, stoppages, environmental conditions like water temperature and current of the water, any pre-dive exercise, alcohol or food that was taken, and what was the condition of the diving equipment and the clothing that was used, any recent dive. Usually frequent divers keep a record in a dive computer, and things like that. Any other illnesses that they have associated and any medications that they normally take. So these are the information usually the specialized center would require when we call them. So what is the help that is available? So in the England, Wales and North Ireland diving incident telephone line, the DDRC, which is the Research Center for Diving Diseases, they all have 24-hour advice lines. The Scotland Aberdeen Royal Infirmary has its own hyperbaric unit, and they have contacts. And there are global links which can be found in diversenetwork.org. If we can't find these easily, then 999 and asking for the Coast Guard might be one of the options. The most important takeaway in the part one is that any symptoms that develop within 48 hours of a dive is due to the dive unless proven otherwise. So thank you for your patience. We will move on to the part two of the marine emergencies, which is basically marine envenomation is a very specialized topic. It can be very complicated, but I'm going to keep it very simple. Uh, and I will base my talk on the patient's presentation itself. So if anyone is coming with a suspected marine envenomation or a marine bite, or basically anyone who has been involved in a sea sport, and then they are coming with a history that something might have bitten them, or there is a sting or something, then how we can classify is that whether it is painful or painless. If it is painless, if there is any puncture, then irrespective of what it was or whether they could see what it was, pressure immobilization should be done, because that will decrease the spread of any toxin. A bandage may be used, and then airway, breathing, circulation, and if we suspect envenomation, then transfer to a specialized center. Supportive treatment is uh, done in most of the higher centers when and the common organisms are cone snail, blue ringed octopus, and sea snake. Important thing to remember is that sea snake has an antivenom, so if that has been identified, then quick antivenomation would be helpful. Now, coming to painful marine envenomations, usually we can distinguish this with tentacles or no tentacles. If there are tentacles, usually it is sea jelly, and whether or not we have identified it, again, airway, breathing, circulation, analgesia, and transfer. If there are any tentacles or nematocysts, then we can try to get rid of them, usually with irrigation or mechanically taking them out. Most of the jellyfish, the treatment is symptomatic: heat or cold pack, analgesia, and topical steroids, because there is a lot of irritation that can happen. And most of the jellyfish, like hair jellies and moon jellies, they cause just localized, less severe reactions. Sometimes it is easier to identify animals with blue tentacles. They are the jellies like Portuguese man of war and blue bottles. In these cases, they also cause only localized reactions, but especially if they have multi tentacles, then they may cause systemic reactions. So these patients might need observation for and supportive care if systemic signs do develop. Now, there are two specific types of jellyfish which might need identification. One is the box jellyfish, because that has an antivenom, and if that is suspected, then a lot of vinegar should be used to irrigate, and hot water immersion at 43.3 degrees Celsius to reduce the pain can be employed, and move on to the antivenom as soon as possible. One very specific and characteristic envenomation is called as Irukandji syndrome, which is caused by the Australian jellyfish, box jellyfish. It usually happens with deep water sport, and there may or may not be any skin marks. And initially, there is minimal pain, but within 30 minutes, when the maximum sympathetic response develops, there is a triad of pain, hypertension, nausea, vomiting associated with diaphoresis, and we need to quickly suspect Irukandji syndrome. Most of the care is supportive, but seawater and vinegar irrigation, IV antihypertensives, IV opioids for the pain, and the tentacle and nematocyst removal. This syndrome may progress into cardiac arrest or cardiovascular collapse, where magnesium sulfate IV has been used with good effect. Now, if no tentacles are seen, then again analgesia, airway breathing, hot and cold pack, and if signs of systemic envenomation, then to transfer to specific center. Supportive care is in the most of the cases that is the main thing, but uh, these kind of uh, envenomations can be caused by fish which have barbs, which are like beard like structures just around the mouth, and if they have got stuck, it can be very difficult to remove them, and they may need specialist referral for wound exploration, anesthetic block, etc. Important thing to remember is stonefish, if it has been identified, then it can cause systemic reactions, and antivenom is available. The other fishes and other rays that can cause this kind of problem are just for supportive care. So, although it is a very complicated topic, I would say that airway, breathing, circulation, analgesia, seawater irrigation, vinegar irrigation, these are the common things for most of these. And if we can identify, then sea snake, stonefish, and box jellyfish, they have specific antivenoms. So identification may be important. Clinically identifying Irukandji syndrome might be something of a specific treatment. So this was in brief talking about marine emergencies, specifically focusing on decompression illness, barotrauma, and marine envenomation. Thank you so much for your patience.